Hello, my name is Marek Karman and you are listening to Kardio MD. Today I have the honor of speaking with two prominent experts in pediatric electrophysiology, Professor Maully J from the Children's Hospital of Philadelphia and Dr. Vieru Illíková from the Children's Cardiac Center at the National Cardiovascular Institute in Slovakia. Both lead electrophysiology and heart rhythm programs specializing in diagnosing and treating heart rhythm disorders in children. Professor Shah also serves as the Medical Director of Diversity and Equity and has previously worked as the Director of PACES, the Pediatric and Congenital Electrophysiology Society. Welcome and enjoy this episode.
Generálny partner podcastu Kardio MD je spoločnosť Timet. Hlavný partner je spoločnosť Medtronic.
It's a great honor to meet you and welcome you to our podcast. And especially thank you, Professor Shah, that you come and visit us and to talk about the electrophysiology during your short medical exchange in Slovakia. Hello.
Hello. Thank you so much for having me.
Hello, thank you.
My very first question, for both of you, could you please explain what the electrophysiology and heart rhythm program involves? What types of patients do you care for, and what age range do you cover?
I'll go first.
Yes.
We take care of patients who have either fast heartbeats, slow heartbeats, patients with genetic conditions that may predispose them to a cardiac arrest. We also take care of patients all the way from fetal life to adult life. We take care of patients who are born with congenital heart disease, who have had surgical procedures and develop rhythm problems after the surgical procedures. So there's a pretty wide spectrum of patients we take care of. And it also involves doing a whole lot of different types of procedures to correct some of these problems.
Yes, I think you told everything. Just maybe also like acquired heart diseases, not only congenitals, but also some like myocarditis or cardiomyopathies. It means diseases of myocardium is also the part of our job. Yeah. And from fetal life, it means that even children who are not yet born, who are still in uterus and in pregnant women, they can have already some rhythm disturbances. Mm-hmm. So we have to treat also these fetuses through their mothers.
Wow, great. That's definitely not my field of medicine. So maybe I have some stupid question, but which diagnostic and therapeutic procedures do you need and use at a daily basis?
Okay. So we will share
we'll share the response.
So it depends on on many things, but the important is the age of the child. So if it's in a fetal life, it's usually drugs given to mom. If they are already newborns or small children, then and all children, there is also possibility of interventional treatment or implantation of devices. It is quite a range scale, and also, of course, drug treatment as in fetal life.
Yeah, I think you summarized that perfectly. In terms of diagnostic procedures, we do everything from a very basic electrocardiogram to longer-term ECG monitoring, to echocardiograms, MRI of the heart, exercise stress testing to provoke arrhythmias, and then sometimes invasive studies to provoke arrhythmias, and then the treatment would consist of a catheter ablation to treat a fast heart rate, or pacemakers for very slow heart rates, or an implantable cardioverter defibrillator for someone who's at risk for sudden cardiac arrest.
All right. Okay. And before we maybe dive deeper to your diseases for a pediatric patient. Could you tell us, are there any specific heart-ridden disorders unique to children compared to adults? I have no idea.
Yeah, I mean, I think essentially for fast heart rhythms that are categorized as supraventricular tachycardia, those are caused by an accessory pathway, and the accessory pathway is congenital in nature. So you're born with it. You can experience supraventricular tachycardia as an adult, but it is not acquired in adulthood. So it's already present from childhood. And so children are more prone to having supraventricular tachycardia. It's probably one of the most common rhythms that we treat in childhood. And then there is a natural history. So for certain arrhythmias, they're more prevalent in children, and this is especially true for conditions that are genetically mediated. The natural history is such that in certain conditions like long QT syndrome, catecholamine-sensitive polymorphic VT, the natural history trend is that the problems occur more during childhood. And if you survive those problems, then as you get older, the episodes of arrhythmias decrease.
And this is the question definitely for both of you. I'm very curious. What are the most challenging cases or barriers in pediatric electrophysiology that you have to deal with? Something special that I can imagine from the adult cardiology.
Yeah, I mean, I'll start by saying that in pediatrics, you're not just dealing with the patient, you're also dealing with the entire family. And sometimes the patient has very little say, right? It's the parents who make all the decisions for the child, and that can sometimes be challenging because on one hand, you want to preserve the quality of life of the child, but you also want to preserve the safety of the child. And sometimes there's a conflict between how you can treat a condition, but that treatment may impair quality of life. So I think the balance of recommending treatments that also preserve the quality of the life of a child and satisfy the child as well as the parents can be challenging.
Sometimes there is a very difficult situation. For example, after resuscitated cardiac death. Mm-hmm. So children survive cardiac death, cardiac arrest. And it's a sporting family, and parents want the child to continue in sports. Mm-hmm. And it's very difficult and also child want to continue in sports. And sometimes now it is it's changing. Last years it is based on some new evidence from studies. It changes that children can participate in sports, but before it was not. But still, there are cases when you advise them not to sport. But you feel that the child is pressed by parents to sport, mm-hmm. or the situation can be also opposite, and it's difficult really to make the balance so both are satisfied and also we are happy and everything is just going. So it's difficult, mm-hmm. and also it's very difficult sometimes that there are situations that child is obviously healthy for 4 years, mm-hmm. and then starts to syncope, to collapse, to loss. He has repeated loss of consciousness, and when you explain the family the situation, they just can't believe it because they can't imagine that how the very, very healthy child can be sick. Mm-hmm. And in between, again, very healthy. So they can't understand it, and it's very difficult sometimes to explain it, and it's difficult for them to get used to it or to accept it. So mm-hmm. There is also other challenge, I think.
And what about maybe technical barriers? do the companies also produce enough devices for you as a pediatrician electrophysiologist, or how is the situation?
This is a problem, I think. Maully can say about this.
No, I think this is a huge problem because children comprise of an important but very small part of the medical industry. So there are no clinical trials based on children, and there are no devices made for children. So we borrow everything from adults. All the technology is borrowed from adults. So one, it's not tested on children, and two, the size is not compatible with smaller children. So this is a huge challenge, and we're constantly adapting adult technology to fit a small child. But I think over the years, at least in the United States, the FDA, which is the regulatory agency for devices, has developed new pathways where devices can be approved post-market based on extrapolating adult data and be approved for children. So I think there is progress, but right now we are limited to devices that are made for adults.
Professor Shah, you have worked with novel catheter and device technologies, including leadless pacemakers and especially in the very small newborns. Can you tell us about your experience in this field?
So a small percentage of patients, children, will need pacemakers. Typically, these are patients who are born with a very low heart rate or patients who have developed a low heart rate after cardiac surgery. And since these devices we've discussed are not made for children, we are implanting these in children from a very young age. And kids, we hope, and we are optimistic, will survive into the 8th or 9th decade of life. So we've got to maintain these devices throughout their lifetime. So it's not like a 60 or a 70-year-old person receiving a device and then you're looking towards the next 10, 20 years. For kids, we're looking at their whole lifetime. And these leads, which are electrodes or wires that connect the pacemaker device to the heart, are the weak link for patients. In a growing child, they tend to fracture. There's a risk of infection. So the leadless pacemaker is an excellent alternative. However, as we said, all the tools are made for adults. And so, again, it's a big risk to put in a leadless pacemaker in a young child. It's possible, technically it's possible, but the risk of the procedure is higher than a fully grown adult. So the family has to take the risk, the patient has to take the risk, and as providers, we've got to take the risk in doing these procedures.
And probably the question is, we don't know how many leadless pacemakers will the child need.
Right. Yeah, exactly, because we're looking at longevity of the child. This is not a short-term solution or a bridge to another technology. And I think this is where the medical industry has to improve, to think about children as their patients and not just adults as their patients.
Maybe just to better imagine it, when you put in small children, you have to put a normal pacemaker into their belly, into their abdomen, and to put electrodes on their heart, on epicardium, on the surface of their heart. So you have to make small sternotomy. And if you put you have 2 kilo newborn and you put pacemaker, the same size as in adults, in which you put it into a subclavicle. So if you put it to the abdomen, the child can have also feeding difficulties because it's big in it's pressure on his stomach. So it's also this problem which nobody realizes, but for us it's a big problem.
Dr. Illíková, if you share some Slovak or in Slovak field some challenges or success stories from your profession or from your career.
Thank you. So I think there are the same challenges and same difficulties worldwide. In our center, we had few very nice stories, not so frequent. For example, we had one child who had from his birth even prenatally supraventricular tachycardias, but very refractory to treatment, refractory like to 3-4 combinations of drugs, and he was still more than 50% of the day in this tachycardia. So this can lead, and it led to cardiac failure. So we had to do interventional ablation of the accessory pathway when he was 5 kilos and 2 months old. And this is with these devices, which are for adults, which are much bigger, like twice bigger than whole child, whole newborn, and you have to put it through the vein to the heart and go transeptally from right atrium to left atrium and then ablate the accessory pathway. Everything is very small. The heart is small. There is AV node. There are coronary arteries. So to do this in 2-month-old child is really difficult, and we were very happy that we did it successfully. Our other successful story was with the child who had long QT, and she had like hundreds, not 10, hundreds of ventricular fibrillation, the special type torsa de Poin, through the day. So she was losing her consciousness hundreds per day, and she was intellectually normally developed. Everything was good until 2.5 years of age, and she had this problem. And then we had also other child who was only a few months of age, and we didn't know, it was, 10 years ago, and we didn't know how to put ICD to these children, because one was 10 kilos, one was 5 kilos. And so we did hybrid system that we put defibrillator abdominally with electrodes on the surface of the heart, and then we put subcutaneous defibrillation lead in the intercostal space all the way to the spine. So then the shock was between that electrode and this abdominally placed ICD, and they could survive. Also, they are treated for sure, of course, because it's painful to get a shock. But if the therapy was not enough, they could be saved by this shock. For example, that one child, she got some gastrointestinal problems, so she was vomiting, so the drugs she took were not really absorbed, and she got very bad ventricular fibrillation. If she hadn't had this defibrillator, she would be dead. So this was also a successful story. Now she's 14 years or 15 years old, and she's doing very well.
Great stories and great success, actually. Yeah.
Thank you.
You both handle very special cases, especially involving congenital heart diseases. What are some of the most challenging situations you face as electrophysiologists, particularly with your patients?
For congenital heart disease, I think the more complex the congenital heart disease is, the arrhythmias are also harder to treat. So, for example, there are some patients who are born with a univentricular heart. So, as you know, you and I have 4-chambered hearts. There are some babies who are born either with 2 chambers, so a common atrium and a single ventricle, or 2 atria and a single ventricle. And fortunately, there are a series of surgeries that can palliate this condition. And the palliations do lead to survival into adulthood, but it's a very complex condition to treat. The more surgeries these patients have, there is more damage on their electrical system. And unfortunately, if you had to put a pacemaker in a fontaine, that's the final surgery that a univentricular heart patient would have, you lose all access to the endocardium of the heart because there are surgical baffles that baffle the blood so that blue blood goes to the lungs and red blood comes to the body. And so because of the surgical baffling, it's impossible to put an endocardial pacemaker. So you have to think about, but the patient's already had 3 open heart surgeries. So even for the surgeon to put pacemaker leads on a heart that has been operated 3 times or sometimes more is very challenging, but we have to find a solution. Every time there's a problem as electrophysiologists, we have to think out of the box and find solutions to treat these challenging problems. So there's never like one treatment for all. It's very much personalized medicine because every child and every congenital heart disease and the complications from that heart disease are different.
Mm-hmm. And maybe I would say that also when you treat patient like this from his birth or from few years of age until adulthood, you really have a relation. So it's like, it's not like the patient and the doctor, it's really relation. And these children start to understand when they are adolescents and adults, they start to understand their disease, and it's more and more difficult for us to discuss with them their fears and their what they can expect in the future, and so this can be very difficult and not easy also for doctors to keep it somehow and to manage it. And on the other side, these children are many times, or adults are many times very grateful that they can live, and they realize much more than their peers that the value of life and the real values. I had one boy, he was called Branyo, and he said that he every day have to do some good thing for others, because then his life is really worth of it, or how to say, in English sometimes it's difficult to express exactly. Nice. And he told his mom that why she is all the time talking about somebody that he died early, that it's not important when you die, it's important how you live. Mm-hmm. Oh, so he already died when he was 33 years of age. Mm-hmm. It was a year ago, but his message for his family and for his friends and for us was fantastic.
Very strong message, definitely.
Yes. Yeah. So this is also very challenging.
Challenging and actually very nice at your field and pediatrician patient that you have really the relationship with and year long or many years, a couple of years.
My oldest patient is 60 years old.
Oh.
So as pediatricians, we actually take care of adults with congenital heart disease. Mm-hmm. So they don't always sort of graduate from the pediatric practice.
Mm-hmm. So they stay in your
many times, because their conditions are so unique that sometimes that type of training is not available in all adult cardiology programs. So unless you have some expertise in congenital heart disease, it's difficult for a general cardiologist to take care of an adult with congenital heart disease, and they tend to stay with the pediatric doctors for a long time.
Mm-hmm. Many times it is also emotionally based, that they go to adults, but then they come back, oh, I would like to be with you. I'm used to, yes. I like it. I don't like to go to adult unit. Mm-hmm. And so we keep them. Yes.
As well as in Slovakia.
Yes, in Slovakia.
Okay,
yes.
Nice. Okay. Let's take a look at more concrete situations. Can you discuss and tell us about the challenges of treating SVTs, supraventricular tachycardias in infants? It's a big topic, but maybe Professor Shah.
Sure, I'll start. So in infants, the primary treatment, as Dr. Illíková spoke about, is antiarrhythmic medications. Antiarrhythmic medications have to be given frequently during the day so that there is an adequate steady state drug level. Otherwise, the patient is going to have recurrences of SVT. And sometimes one medication doesn't work, and we have to put the patient on multiple antiarrhythmic medications. And these antiarrhythmic medications can interact with each other. So you could create a situation while you're treating one arrhythmia, you could create another arrhythmia, like a proarrhythmia. And in an infant, this is difficult because a baby is not going to tell you if there is a side effect or a complication. And so this puts a lot of onus on the parent to observe their babies or infants constantly. I mean, it's disruptive to their life. And sometimes medications don't work. And one of the examples Dr. Illíková gave you was when medications don't work, we have to do a catheter ablation early in life with catheters that are not meant for babies, let alone children. I mean, they're basically adult catheters that we're using in babies. So I think this is a challenge, and there is also a type of arrhythmia where the heart rate it's still supraventricular. The heart rate's not that fast. It's called an ectopic atrial tachycardia, and it's difficult to differentiate it from sinus or a normal tachycardia. And this, if it persists, can lead to a cardiomyopathy. And unless you really observe the ECG carefully to look at the changes in the P-wave axis, it can be overlooked as a sinus tachycardia. So again, because the baby or an infant cannot talk to you, you depend on these sort of objective observations. And you have to really make the correct diagnosis. And if you miss the diagnosis, children with SVT can develop cardiomyopathy.
And at what age we can tell that catheter ablation can be at least similar successful as by adults? Is any age?
So the guidelines for us for elective catheter ablations is over the age of 4 years and over 15 kilos. But I don't think that is similar to adults because, I mean, think of a 15-kilo child versus a 60-kilo adult. So while it is technically possible, it is not the same procedure. I think you have to be very careful, and everything is close together. The coronary arteries are 2 or 3 millimeters epicardial to the valve annulus where you're trying to ablate. The AV node, as Dr. Illíková said, is few millimeters from the ventricular septum. So you have to be extremely, extremely careful. And sometimes you have to bail out of the procedure because the risk of the procedure is higher than the treatment.
So we definitely meet as well patients with AV blocks after the cardiac surgery, and before they had no arrhythmia. So the cardiac surgeons made you a new patient, actually. Can I imagine it so?
The new diagnosis in the patient. Before it was just congenital heart disease, and then it is also AV block with the need of pacemaker implantation, yes. And yes.
Would like something to add to the topic supraventricular tachycardia? You had one special patient or one perfect case?
Yes, we had one special case. We had a case, and she was not even infant, so she could tell that she has some problems. But she was 11 or 9, I don't remember exactly. But she was admitted to one hospital in Slovakia with very with really serious heart failure. So they wanted to do transplantation. So they sent her to our center for heart transplantation. So that bad it was. And it was just atrial ectopic tachycardia in this girl. And we did ablation. And in 1 week, she was completely healthy and didn't need any medication. So it was for the parents, it was like a miracle. So it can happen not only in infants where it is more understandable and more often, but it can happen also in older children if you don't have ECG. And I don't know how it is in USA, but here, for example, my children, I made them ECG when they were like maybe 12 years old or so, because you don't, in newborn period and also you go regularly to the doctor, but they don't do ECG.
Yeah, right.
So when I was doing one study years ago about WPW in newborns, that time many neonatal units in Slovakia bought ECG because of that. So this is...
Oh, that's great.
Yes, it was not the aim of the study, but it just was bringing this new good thing. So now they do ECG more often, much more often than before.
I do want to add one thing. We've talked about a lot of challenges with treatment of SVT, but I want to tell you that it is probably one of the most gratifying diseases to encounter, because the success rate, despite all the challenges with catheter ablation for supraventricular tachycardia, is one of the highest of any procedures in the field of cardiology. So the success rate is over 95%. And so you could have someone with a lot of symptoms, and despite all the challenges we've talked about, you can provide a complete cure to that patient within a matter of hours with the procedure, and it'll change their life.
Yes, it is like really miracle, and it is one, maybe it is very, very rare that you can really causally treat the patient and return him to completely normal life, to sport, to competitive sport, to do anything the patient wants, to completely normal life. So that is really fantastic. One day you admit sick child, second day you treat him, third day going home healthy. So this is fantastic.
Lovely. Okay, so now let's explore the treatment and management of ventricular tachycardias across maybe age groups. It can differ, I don't know. So maybe Professor Shah?
So ventricular tachycardia is an unusual tachycardia in a healthy child. Mm-hmm. And if you encounter a child with sustained ventricular tachycardia or polymorphic ventricular tachycardia, you really need to dig deep into finding a cause for that. And some of the causes that you want to rule out as soon as possible are genetic channelopathies that may predispose the child to a future cardiac arrest or a cardiomyopathy. So sustained ventricular tachycardia requires a lot of diagnostic testing. However, if you just have PVCs, premature ventricular contractions, is that what you say here too? That's extremely common in children. Totally healthy children will have PVCs, and they can go away when they get older. Very rarely do they cause a problem. But if you have sustained ventricular tachycardia, you need to rule out myocarditis, you need to rule out cardiomyopathy, you need to rule out any kind of genetic condition that might predispose to ventricular tachycardia. So it should be taken seriously.
Do this patient become as well some emergency VT ablation? Is it similar to the adult patients, or is it another management of these patients?
It depends on the cause. If it is sustained ventricular tachycardia that is monomorphic, without a clear underlying cause, what we would call idiopathic ventricular tachycardia, that's curable by catheter ablation with a success rate probably as high as supraventricular tachycardia catheter ablation. But if there's an underlying cause, then you have to treat that underlying cause, and that may be genetic mutation-specific medications, and sometimes an ICD, and rarely a procedure called a sympathectomy, which is cardiac neural denervation, because there is an adrenergic trigger for these arrhythmias that cannot be blocked by beta blockers or conventional medications. So there is a procedure which we call left cervical denervation, particularly helpful in long QT syndrome patients who have recurrent arrhythmias. Essentially, that can totally stop the arrhythmias.
Would you like to add something, talk about something more, or is it for you?
Maybe that you also asked that if we do like emergent VT ablation. So in Slovakia, I don't think we do it. Usually we put first some drugs, if the patient is hemodynamically unstable, we defibrillate him, and then we plan this ablation later. So it's maybe not different than in adults, which when they do like emergent ablation. So we don't do it. I don't know. Maybe you had such cases.
Yeah, I think if a patient is really sick and we have to do an emergent ablation, we would have to have them on some kind of mechanical support to do the ablation, because otherwise they wouldn't tolerate it.
Okay. Thank you for coming, and we really appreciate it, and we are grateful you joined us on our podcast.
Thank you so much.
Thank you very much.
Okrem našich pravidelných stretnutí pri podcaste Kardio MD pre vás tvorím aj odborný kardiologický newsletter s rovnakým názvom. Je určený pre všetkých súčasných aj budúcich kardiologov, internistov a všeobecných lekárov, ktorí majú chuť rásť, inšpirovať sa a zdieľať svoje tipy v komentároch. Každé 2 týždne vám vyberám zaujímavé štúdie, kongresy, aplikácie, rozhovory a klinické tipy z kardiológie, ktoré zaujali mňa na mojej kardioceste. Nezabudnite sa prihlásiť na odber prostredníctvom linku v popise. Ďakujem, že ste s nami.